of get us started, but I wanted to start off the webinar by just saying that I am so grateful that everyone is joining us for this second session of the webinar series around pain management in labor and delivery. Today's session focuses on pain management for obstetric patients with substance use disorder, a topic that requires both clinical expertise and compassionate, patient-centered care. Patients with substance use disorder often face unique challenges during pregnancy and the postpartum period, including stigma, concerns about pain being undertreated, and the need for coordinated care across disciplines. The goal is to provide practical, evidence-based strategies that help healthcare teams manage pain safely while supporting recovery, promoting trust, and improving outcomes for both mom and baby. So today's webinar will be discussing principles of trauma-informed care, considerations for patients receiving medications for opioid use disorder, and approaches to delivering and developing individualized pain management plans that align with the ERAS principles that were talked about during our first webinar. Before I move on, I do introduce our speakers. I'm going to do a couple of housekeeping reminders, and then I am going to open us up with just some thoughts from one of our certified recovery support specialists. And for those who are joining, my name is Honor Hill. I am the Director of Maternal and Infant Health Initiatives for March Times in Alabama, but I also serve as the chair for the Maternal and Child Health Substance Use Committee under the Alabama Opioid Overdose and Addiction Council. So super grateful for those who are on the committee to help kind of create these webinar series, but also for being able to get us insight from a certified recovery support specialist before we dive in. So before all of our technicals that we're going to get into, I just wanted to say some words from Danny, a certified recovery support specialist, and kind of her story and her thoughts that she would like to share before we dive in. So Danny says, I gave birth 6 years into recovery. I used fentanyl while in addiction, so I was very mindful of taking any pain medications. The doctors knew my history and asked them only to give me low-dose pain meds, alternating with NSAIDs after delivery. It worked well for me because I went in with that mindset on the forefront, and I didn't leave the hospital with any pain meds either. I would like the doctors to think about how each lady is different and try to tailor an L&D plan based on the individual. For someone who has a stimulant use disorder or an alcohol use disorder, pain meds while in the hospital might be compassionate and humane. However, if they've had an opioid use disorder, they still should not be refused pain medication. So as medical staff continue to work with patients, I want them to know that our thoughts may be very shameful and intrusive when we are triggered, and patients should have access to peer or a sponsor prior to discharge. Reminder that you can call a peer just as you would a language line if the peer is not in the hospital, such as the Ross 24/7 hotline. As for stigma, it felt like the staff could be very nasty and say mean comments to my face. Just because we are in recovery does not make us give them the right to say hurtful, mean things, especially in active addiction or even remote use. We're already ashamed and dealing with mental peace that comes with staying sober. When she was asked about other folks that she works with within recovery, she said she did have a patient once tell her that DHR was called on her because she tested positive for something the hospital gave her. And so as they did try to correct it, but the damage had been done based on her history. So in closing, Danny wants the hospitals to consider medications that yield false positive and the impact it has when testing postpartum, and to talk to them as if they're human. We're afraid and do not know what to expect. All right, just a moment just to take in kind of Danny's perspective as she works in recovery, and as someone who did deliver in labor and delivery while in recovery. Just for you all to know, this webinar is being recorded and will be available today or after today's session so that you can share with others or have others if you that might not be here, have them listen to this. You can also submit your questions in the chat or through the Q&A throughout the presentation, and we'll reserve time at the end to address the questions that you have. Thank you for being here and for your commitment to providing compassionate, equitable care. With that, I'd like to introduce today's first speaker, Dr. Sonia Williams. Dr. Williams currently works as the Medical Director of Behavioral Health Group in Coleman, Alabama. She's a fellowship trained and board certified in addiction medicine, as well as board certified obstetrician and gynecologist. She entered the field of addiction upon recognition that many of her patients required more treatment than they were able to obtain within the confines of her rural practice area. Feeling both a dire need and a personal lack of training, she entered fellowship in addiction medicine at St. Louis University of Medicine after 18 years of OBGYN practice. Her specialties include the intersection of pregnancy and substance use disorder and trauma and substance use disorder. Dr. Williams, whenever you're ready.
All right, thank you. Welcome, everyone. Hopefully, you'll be able to get a lot out of this presentation. I have a feeling most of you are coming from more of a hospital practice and maybe looking for some tips on how to manage care for patients that you're seeing in labor and delivery. We'll review that as well as a little bit of information on kind of things to look out for and how to identify your patients who may be at risk of a use disorder, not just in the midst of use, which can be two very different things. So again, we're going to talk a little bit about why labor and delivery pain management and substance use disorder, why we want to look at that, what the healthcare costs can be and the consequences, a little bit about screening and testing, pain management, and medication treatment. So when we're looking at why does this matter, we know that pregnancy substance use rates have definitely increased over the last 10 years. I know most of you have been experiencing that in your practices and noticing that in the hospital. It's not just something you're noticing, that's definitely in the statistics. The OUD or opioid use disorder rates have increased, and the number of prescribed opioids had increased significantly. And a lot of this data that I'm going to go through in my talk today will be directly from the Society of Maternal Fetal Medicine Bulletin published in 2019, which has some of the most up-to-date maternal data that we can get nationwide. And so that's part of why the numbers say that the prescribed opioids had increased quite this much. I will tell you from our opioid council meeting yesterday that in the state of Alabama, that prescribing has decreased, which is a huge improvement. So what I'm showing you here is some of the information from the CDC and looking at the PRAMS data, the Pregnancy Risk Assessment Monitoring System. And as you can see from that data, substance use disorder in pregnancy is one of the complications that we have seen. We've seen an increase in maternal pregnancy-related mortality, a lot of that having to do with substance use disorder up to 2017. We know from 2017 up to about 2023 that increased continually from in terms of use disorders and what we were seeing in the public. And just recently, we're seeing a decrease in mortality for the first time in years. I'm showing you here some data both from the CDC on your right and from the state of Missouri on your left. Having trained in fellowship at St. Louis University, I'm showing you this data because it was readily accessible to me. They have NAS or neonatal abstinence syndrome discharges in the state of Missouri that are tracked and published on their substance use disorder dashboard on a monthly basis. So you can see it continually being updated. But as you'll see from this data, up to 2022, we saw a slight decrease between 2021 and 2022 in our neonatal abstinence syndrome discharges, but still they're pretty darn high compared to 2017. Remember, neonatal abstinence syndrome can encompass all withdrawal syndromes, whether it be the antidepressant Wellbutrin, whether it be stimulants, whether it be smoking, or nicotine consumption, or opioid use disorder. I think commonly people will use the NOWS, or neonatal opioid withdrawal syndrome, and NAS interchangeably, but I think it's important to remember that NAS can show up from a number of different substances and even impact the Finnegan scoring. If your hospital's still doing Finnegan scoring, then that can impact those scores, or the withdrawal scores. So 1.5 billion was the impact in the nationwide, according to the Society of Maternal Fetal Medicine bulletin that was put out in 2019. That was our NAS burden nationwide. In Missouri, I'm going to show you some diagrams to give you an idea of the progression of opioid use so that you can have a better picture of what this has looked like over time. So back in 2010, what we were seeing is more heroin and occasionally a synthetic opioid, and very rarely a combination of the two. Back in 2016, you'll see that those almost equilibrated all three spheres of use and what we were seeing in the data. As we progress to 2020, you see that synthetic opioid use, we're talking about things like fentanyl, carfentanil, xylazine, what we now are seeing more is medetomidine. All of those have increased really far surpassing heroin or even the combination. And then here we have 2023. And I like showing this data because those spheres are so impactful. It really helps me remember what a huge problem that this became. Back in 2024 and 2025, we saw that those numbers began to decrease, but the ballooning or escalation and logarithmic increase in the number of people that were struggling became really high. So identifying who is struggling with an opioid use disorder or methamphetamine use disorder or alcohol use disorder begins with screening. A lot of people think that screening is urine drug screens, and that is absolutely not the case. The Society of Maternal Fetal Medicine and the American College of Obstetrics and Gynecology do not recommend using urine drug screens first line. Your first line screening test is a verbal initiation of communication using one of our validated tools. One of them can be the NIDA Quick Screen, and some of the others are the 4Ps, the 5Ps, the CRAFT, and the DAST. If you are unfamiliar with what those are, please take a screenshot of the next slide that goes through those titles, and you should be able to look on your MedCalc calculator or even through Google and find those screens quite easily and in a way that you can use them at bedside. The consent before testing is recommended by ACOG. The American College of Obstetrics and Gynecology states we should never be doing any testing on a patient without their express permission, with the exception of if they are obtunded. So if a patient cannot provide consent, they come in and they are unresponsive, then absolutely we should be getting urine testing, blood testing, all of those sorts of things. But otherwise, we want to be very cautious about doing any kind of biologic testing on a patient without their permission. In many states now, that has gone to written permission. In the state of Missouri, you do not get a urine drug screen on a patient unless you can document that they are obtunded without written permission of the patient. And in part, this is because of the concerns about legal and stigma repercussions. But in the state of Alabama, this is particularly concerning. Our current chemical endangerment laws that are on the books allow the Attorney General to press charges against any woman for any drug screen that comes back that is not therapeutic. This is concerning because We know that fentanyl in particular, most of the time when it comes back positive on a point of care cup, so an initial test where we just pee in a cup and you get the result, that only 20 to 30% of those are actually positive. And based on those false positives, charges can be dropped on a woman. So we want to be very careful about what we're doing, what tests we're ordering, so that we're not putting people in a position where their entire family is being traumatized, torn apart, and legal charges based on an abnormal test. Um, and then we don't want to have just universal biological screening again. So these are the four typical screenings that we see that are recommended by Society of Maternal Fetal Medicine and ACOG. The four Ps or the five Ps, they've just added another P. That is the one that we most commonly will see used in an OB setting, usually OB triage. The NIDA screen, many people like that one. I personally, working in addiction, find it extremely difficult. I think it's a more difficult screen just because it's one of those screens that asks people sometimes, never, always. And when someone is struggling with use, or they're in pain, or they're in withdrawal, it becomes very difficult to answer those nuanced questions. Whereas the five Ps, four Ps, I think are much easier for people. The craft is recommended for adolescents, so those under 18. We find that teenagers are more able to answer questions about their friends and family as opposed to themselves, and they're more apt to answer honestly. So the craft is developed based on adolescent behavior and is peer validated. The DAST is a very long questionnaire. It's a great questionnaire, but again, a very long questionnaire that goes through a lot of different substances. It has its place. It's a great one, but again, it's a little more challenging for a quick screening of your patient who comes in off the street. So again, you're in drug screening. We want to be very careful about who we're testing, when we're testing. Again, the concerns for that are legal implications. There are false negatives as well as false positives on all of our testing. And loss of prenatal care is a documented issue, especially in states where chemical endangerment laws are in place. We know that women who do a urine drug screen and it comes back falsely positive, falsely negative, or even accurate may not seek or continue to seek prenatal care based on legal repercussions or concerns about legal repercussions, whether they be true or false. Antepartum management for someone who does have a substance use disorder. The standard of care is to maintain their medication. Any of the medications that they may be on for the treatment of their use disorder are safe in pregnancy. We used to have concerns about naltrexone or the buprenorphine combination with naloxone, or naltrexone, that should say naltrexone, I apologize. But we have numerous studies now showing safety of the naltrexone in pregnancy. So the Vivitrol shot can be given, Suboxone can be given. You do not have to stop someone from taking Suboxone and switch them to Subutex anymore. We have very good documented data showing that if they're already on it, they're fine, and that even if they aren't, if you're starting therapy, that starting with the Suboxone is okay. In terms of how do we take care of someone throughout their pregnancy when they have a documented substance use disorder, we want to make sure that we're monitoring fetal growth. For our individuals who struggle with a substance use disorder, nobody fits into one bucket or picture, but at the same time, many of our patients may struggle with things such as being unhoused or nutrition or any number of things. So monitoring fetal growth from 28 weeks on about every 4 weeks would be reasonable, not only because they're on treatment medications, but also because of a number of other illnesses that travel in the same train. Our trauma-informed care is very important. And when we talk about trauma-informed care, we want to make sure that we're emphasizing that all of your care is patient-centered. And when I say trauma-informed, you want to be very careful. I think most obstetricians are pretty trauma-informed in their practices, but just to reiterate, trauma goes along with substance use disorder in a lot of cases. We know that a number of women who struggle with substance use disorder will end up in that realm or under that umbrella because of a history of childhood abuse or neglect or sexual abuse, in addition to intimate partner violence being increased. So it's real important to remember that we're dealing with a very traumatized population when we're dealing with someone who struggles with substance use disorder. Motivational interviewing and patient-centered interviewing are a part of our therapy. EMDR is really important for our traumatized patients and CBT. So pain management in the opioid naive patient, all of us are, I think, are pretty comfortable with this. This is just your baseline bread and butter. How do I take care of someone who comes into labor and delivery? Using your NSAIDs and acetaminophen first line for a vaginal delivery, unless someone has had a fourth degree laceration, we're not going to be looking at using anything opioid in nature for treatment of pain. Opioids only for severe pain, assess complications early, looking for anything unusual. And then cesarean, same first line medications, and then adding opioids as needed. Now, when we're looking at patients that are intrapartum for opioid use disorder, we want to make sure that we continue their medication primarily. If we take them off of their medication for opioid use disorder, we're going to be throwing them into a withdrawal, which increases their pain and anxiety, which will make their pain management more challenging. So it's really important to maintain their medication and then treat on top of that. For a vaginal delivery, we do recommend judicious use, or not judicious, but very, very liberal use of epidurals and using your IV pain medication. When you're using IV pain medication, remember you cannot be using Nubain or Stadol. Both of those have blockers in them, and we will put someone into a precipitated withdrawal by pushing all of their medication for their opioid use disorder off of the receptor. It's also important to remember those probably aren't our first line anymore in the day and age where fentanyl is as common as it has been, because we certainly have, if we have a patient who we are unaware of a use disorder with, then we can find that using those medications can also put them in a precipitated withdrawal. So whereas that used to be our baseline, somebody comes in, I'm giving them Nubain for pain, we're not using that first line any longer. So for cesarean pain management, we want to make sure that we're using those ERAS protocols. Tap blocks are awesome. If you have an anesthesia group that's really good with tap blocks, use them and use them well. And then pain pumps. I will tell you that my small hospital started using pain pumps at the suggestion of one of my colleagues, initially for just our patients who are struggling with medication for opioid use disorder. Those pain pumps are catheters that go through the anterior abdominal wall, usually just below the umbilicus, but above the cesarean incision. And then they lay in that anterior cul-de-sac and drip some ropivacaine into that abdominal cavity following surgery. And those decrease the MMEs being used by our OB facilities in half. Primarily not because we had so many patients that were struggling with opioid use disorder, although we had a pretty high percentage, but also because we began to find that those patients were doing so much better than our patients who did not have opioid use disorder that we began using the pain pumps for everyone. And that decreased the number of opioids being used within our facility. So they're pretty amazing, and I would highly recommend them if you have the opportunity to use them. So, discharge and stewardship, making sure that you're counseling patients regarding risks and benefits of the use of any substances they're using on the street or their medications that they're taking. Make sure you review, of course, all the side effects. Prescribe very few pain pills and reduce leftovers to reduce diversion. One of the other things you might also want to consider with this, NIDA has an opioid prescribing tool. Again, that's also can be found in your calculator. And it's a really great thing to use if you're ever prescribing an opioid. You can pull that up and it will give you the risk of someone developing an opioid use disorder or any use disorder based on your prescribing habits. So it's a really nice tool. One of our hospitals in Missouri did have a major lawsuit regarding a patient dying from an overdose. And following the lawsuit being settled, part of the settlement to prevent any problems happening in the future was that opioid prescribing tool was attached to every opioid prescription so that a physician would have to evaluate that before they wrote an opioid prescription and have it sent electronically. At first, it seemed like kind of a hassle, but then you would begin to find patients that were at risk that you may not have thought of before. So really kind of keeping yourself mindful of those points will be very important. Medication for opioid use disorder is the standard of care. If we have someone coming in and they evaluate in your screener as perhaps having a problem, please consult your addiction specialist that you have in your hospital if you have them. If you don't, I'd be happy to give me a call and I'll help you out with that. But certainly looking at your diagnostic criteria, the 11 questions in the DSM that help us diagnose a use disorder would be the next step. Remember, our screening tools give us a red flag that this person might be at risk, but then our DSM questions give us the diagnosis. So just because someone's screened as a problem with your SBIRT doesn't mean they have an issue. It means that we need to get more information. But if someone comes up with the use disorder diagnosis following that, we want to make sure that we're continuing them on medication, offering them maintenance therapy, offering them a warm handoff to a treatment facility, and individualizing treatment based on what the patient feels most comfortable with. And again, that medication is the standard of care. Coordination of care models, basically, we want to make sure that we're doing those warm handoffs. If the patient is choosing methadone treatment, you want to make sure that you're calling your local methadone treatment center and you're able to get them an appointment. Some of us have protocols set up. I know my facility has a program set up with UAB where if the social workers call us and they have someone in the hospital they're discharging that is looking at methadone for treatment or they've started on methadone, I can do their admission from their hospital bed. And that way we can improve the adherence to treatment and follow through. In terms of the ethics, remember just all of these legal terms and ethical terms, again, are really important to remind us, patients have a choice in whether or not they allow us to do testing, they allow us to provide treatment for them. They have a choice to turn away from treatment. And the most common instance where I find that patients do that is either they just aren't ready for treatment yet, or they are feeling judged by the staff or the physician who's offering that. Um, so let's see, harm reduction. This slide just kind of goes through the things that we teach people about harm reduction. It's really important for if people are not getting treatment that we make sure we tell them, we send them home with a Narcan prescription. Anytime we write an opioid prescription of any kind, we should be sending them home with Narcan. We remind patients never to use alone, to avoid benzo or alcohol use with any opioids, clean needle techniques. We have a handout that we give people that goes through areas that are the greatest risk for causing problems from dirty needles. Remember that HIV PrEP should be offered to patients if they are using substances IV or if they're sexually active. So basically, all of our pregnant patients who are using substances should be offered HIV PrEP. Um, and then maintaining prenatal appointments is really important, et cetera. So, in the light of stories that help us improve care, the one that I typically share with people regarding patients and their outcomes is, and the person that really got me started down this path of treating people with substance use disorder was a patient that I had taken care of through her pregnancy who, after delivery, one of my colleagues, who happens to be a beautiful human, a very astute clinician, happened to walk in while she was with three of her coworkers, not thinking that these were coworkers, not family, and began to ask her about her hepatitis C. And the patient was devastated because these coworkers had no idea that she had a history of substance use disorder. The patient nearly fell apart. The nurse called me on my day off to come in and talk to her. And she had never really spent a great deal of time talking to me about her substance use disorder. It wasn't something that was on our radar. She wasn't using currently. She hadn't had any use in over 5 years. But as I sat down with her and began to talk to her about her experience, her story was just breathtaking. Her custody of her was given to her uncle following her parents' death in a car accident. And within a month of her uncle having custody of her, he had struggled with a substance use disorder for quite some time, and most of the family was unaware of it. But he began shooting her up and selling her to his friends for more drugs. She ended up within a substance use disorder and caught in that situation for at least 4 years. Before she became 18, she left the home, and then she says she locked herself in a closet until she came off of the heroin and was able to rejoin society. She never used medications. She didn't get any kind of help. She was so embarrassed and ashamed of everything that happened, despite it not being her fault. She wouldn't speak to people about it. So this instance of her being spoken to about her hep C in a way that was very demeaning nearly pulled her apart. She made the statement to me of, why did I go through all of the pain and suffering of recovering from this if people are going to treat me as though I'm an addict, when really all I did was survive. So I think it's important to hear stories like that because they change our perspective. Many of us have an idea or picture in our head of what someone looks like when they're struggling with a substance use disorder, and it can be very different than what we have in our head. So that's what I have. Honor, I'll send that back to you.
Thank you so much, Dr. Williams. We so appreciate your expertise. And I can't wait for the Q&A at the end. I know I have some questions. Danny had some good ideas in her testimony that I'd love for us to chat about if we have time. So next up, I know that was some incredible information, and I'm sure you all are wondering, okay, how do we put this in practice at our hospital? So next up, we have LB Brown from Vital, Alabama, and she'll be going over opportunities for technical assistance, training opportunities, quality improvement resources available to help strengthen care for patients with substance use disorder, as well as implement some of these evidence-based practices. So LB Brown is a licensed clinical social worker, a perinatal mental health certified provider, and a certified financial social worker. She serves as a project manager for every step through Vital, where she leads statewide initiatives focused on perinatal behavioral health and SBIRT implementation. LB is passionate about reducing stigma, strengthening systems of care, and improving access to compassionate, evidence-based support for women and families across Alabama. LB, over to you.
Can y'all hear me okay? Am I loud enough?
Sound
Okay,
great.
great.
You sound great.
Okay,
Yeah.
awesome. Thank you. Awesome. And thank you, Dr. Williams. That was amazing, amazing information. And I'm always just so impressed how y'all keep that information in your brain all the time. So so grateful for that. And I'm excited to expand on this, on the management part, or perinatal management. So let me get well, before I start sharing my screen, just curious, who all here, if you could put in the chat, if you have heard of or are familiar with expert at all. It helps me get a sense of how to kind of talk around it a little bit better. If y'all can, I'm just gonna wait and see if we have not. Okay, cool. And then also when I start sharing my screen, give me a second. My computer likes to take its time to that. Okay, cool. So I have probably half and half in here. Not from, okay, cool. Thank y'all. Sweet. All right, cool. Well, like I said before, I'm always impressed with what y'all do, and I just also want to say thank you for what you're doing. I know it's like all this information can be heavy, and so thank y'all for sharing it. As y'all can tell, I am a clinical social worker, so that's why there's that. So let me get my shared screen. All right, and now let me present. All right.
It's going. It's going. It's taking its.
Here we go. Can y'all see it?
Yep, you're good to go.
Perfect. Thank you. All right. So, Honor mentioned about Vital, and Vital is there we go. Okay, I got to do this. Okay, here we go. So Vital is a statewide applied research and technical assistance organization that partners with Alabama state agencies to improve workforce wellness and policy. And there are a lot of team members on Vital, and they work within the community and organizational stakeholders around the 67 counties in Alabama. And the project I'm managing is called Every Step, and it's a collaborative project between Alabama Department of Mental Health and Alabama Department of Public Health and within Vital. I've already seen the introduction here, me. So I'm going to discuss the role of expert, which is screening, brief intervention, and referral to treatment, and other trauma-informed, patient-centered approaches in identifying and supporting pregnant postpartum patients with substance use disorders, and then also identifying technical assistance, training opportunities, and quality improvement resources available to help hospitals strengthen your care for patients with substance use disorder and implement evidence-based practices. So within Every Step, we are focused on reducing the infant and maternal mortality rates in Alabama. And by doing that, we utilize the expert model to reduce substance use, depression, and domestic violence among individuals who are pregnant or attempting to become pregnant. And so expert stands for screening, brief intervention, and referral to treatment. So it's evidence-based. It uses validated screening tools, universal screening tools, and it has the spirit of motivational interviewing. And I don't know about y'all, but if I can get this refresher about motivational interviewing at least once a year, I mean, I take it every month if I could. It's so great to have that refresher or practice, and to be able to practice and really learn it, to be able to then utilize it with your patients. And so expert improves outcomes for chronic diseases and can contribute to the wellness of patients. And so the primary goal of that of expert is to identify and effectively intervene with patients who are at risk for psychosocial or healthcare problems related to their substance use. And so this is important to do with universal screenings. It's so important, it matters because we are the third highest maternal mortality rate after Arkansas and Kentucky, and less than 1 in 5 women were screened for perinatal depression in 2024. And we all know or should know by now that mental health and substance use disorder are, go hand in hand, right? And trauma as well. So it's super important that we can screen for things that maybe we wouldn't usually, right? So Over 20% of women will be diagnosed with a mental illness this year, and co-occurring disorder rates are highest between the ages of 26 and 49. And this helps to normalize the conversation for everybody and really takes away that like stigma, suspicion-based screening around that. And then with that, it just organically reduces stigma, increases disclosure, and it really helps the outcome of your patient-provider relationship and really strengthens that. And just a quick, like when I spoke about motivational interviewing, also just want to throw in some trauma-informed language that can really wrap into motivational interviewing, and that, you know, everyone would utilizing a sense of safety, empathy, and respect with your patient. And then it kind of helps us transition from using words like clean or abuse and kind of that more like substance use or in recovery or receiving treatment. So words matter, right? So this just helps take that and restructures it. And with the universal screening, you're directly asking every single patient, and you're saying, I ask all my patients about substance use during pregnancy. How are you doing with that, right? Which sounds very different than are you using, have you used, things like that. So that's kind of where the foundation is with the expert and motivational interviewing. Oh no. Okay. I made that meme, so I'm excited to show it. We got a preview. So just to kind of this is a quick overview of expert and what we do here at every step. But I really like the visual because it kind of helps, it provides that support, see, right? Like, okay, if I ask, then if she says yes or says something, what do I do? Just kind of help take that away. You're treating everybody as universal. You're telling that patient, we're asking everybody this. And then expert and what we do, it provides these screening tools. Now I know in hospitals, like there's obviously have your EHR and things like that, you know, but within every step and how we support, and I'll get to this later, but how we support organizations is that we can look at the EHR system and say, okay, can we ask an additional question? Can we change around these words based off of these screening tools, right? So it kind of goes back to that always never question. We have things that really go like how often, or including like medications, right? Like not just what standard drug use is, right? So or what people think it is. So screening tools, audit, that GAPS, nicotine screen, PHQ-9, intimate partner violence assessment. So these are like the full assessments. We do have shorter ones that you can utilize before going way into the whole screener. But you get this chart over here shows like what the scores are, right? Like, and then based off of those in that triangle, it's like, okay, what intervention needs to be provided at each level, right? Whether it's just myself providing motivational interviewing right there, or does this require a referral or a consult, things like that. So it's very structured, very hands-on from our end. So I feel like in my experiences, sometimes there can be different feelings around like substance use disorder or just talking about substances, whether it's just having that conversation or worrying about what happens if he says yes or screens positive. In my opinion, there's a lot of different feelings around it from every different person, right? So right here on this meme that I created, I have the fear of saying the wrong thing could be one thing that expert can help provide support in, because that can come up a lot. And so since it's universal, since there's screeners, since there are trainings around motivational interviewing, you could really take that off of like just having that fear, right? This allows that. So when I'm talking about this, I don't want to add more plate. It's not supposed to do that. It's supposed to help support you and help carry what's already on your plate. Take that, heaviness really off of you. Because we have training, we have screening tools, and we work to strengthen referral pathways. So we have already done work in building and testing and just really there to support you and your organization in doing this, right? This is the other one. I could have made a whole lot more, but these are about two. Or if it's like you're just waiting for patients to bring it up, if they do, right? And so again, it's like universal screening looks way better than waiting for some. So anyway, that's fun. All right, so here at Every Step, we provide providers, communication, community training, and education. We go off of evidence-based practices. We provide expert implementation, consultation, and support. And really, that looks like it's unique to each implementation site that we have, just based on a lot of different information, like the size and all the things that are in place already. So it's very unique support. We have educational resources and dissemination. So if you're looking for more educational tools around this topic, we have that. We'll soon come out with a provider toolkit as well. So we have amazing resources. We can also, I'll share my contact information. I can send these to you. I can send a digital copy or a physical copy. Like we have these nice, I don't know what they're called, rack cards or stock cards, just hand out. And this is so important to be knowledgeable about, or you can share with your client, because we know that pregnant and postpartum individuals face barriers to seeking care. Dr. Williams already talked about fear of stigma, judgment, and then system involvement, right? So ESPER is, while evidence-based and successful to behavioral health early intervention, its effectiveness really depends on the environment in which it's delivered. And that's where we come in. So we have here at Every Step, we have something we call a care certification. It stands for compassion, accessibility, recovery, and excellence. And so what we do with this is equipping perinatal provider organizations. And we've just started working with individuals to deliver compassionate, stigma-reducing, and evidence-informed behavioral health care across pregnancy and postpartum periods. So we have training, surveys, assessments, and then, like I said before, like customized expert implementation. And then the care certification strengthens the systems and individual professional practice to support early identification and recovery-oriented care for substance use and mental health concerns across maternal health populations, which, again, I don't know about y'all, but with me, this is a heavy topic to talk about. So this helps provide that structure and that support and the training. And it's for healthcare, perinatal health providers, behavioral health organizations, community health workers, and maternal health serving agencies and individuals across Alabama who are dedicated to best practice maternal behavioral health care. There's two pathways: community organizational pathway. These are the things that's involved in those, right? Included. So you have a statement of commitment. We're talking about building substance use disorder informed practices into your hospital or clinic. Technical assistance, like within your EHR, really looking at that and seeing how we can modify or enhance questions that are already asked, and then ongoing support along the way. And then we have a care certified designation to display and share publicly, so a digital badge that you can put like on your email, or we can, we're planning on also having patient education or things you can put around your organization to kind of help share the word of like your commitment to compassionate, accessible, recovery-oriented, and excellent care, right? Individual pathway, basically the same, but in a different way, right? Delivered in a different way. You're completing a statement of commitment. You'll have expert and trauma-informed care training. You get a badge, and then that way you can apply what you learn and or get refreshed directly in patient care, right? So I'm so excited about this. So yeah, so we'll support you along the way, which I think is so vital, in having that village, right, for providers along with the patient. So you receive that consistent high quality support and consultation during and after the certification. You have free online, virtual and in-person training. Yeah, and it depends if it's a community pathway or individual, but there'd be an organization specific customer request for implementation. So this is a form to take time. Oh, good. Oh, great. Okay, if you're interested, so again, this is a short version, but if you're the least bit interested in about a care certification, organizational, or individual pathway, you can scan that code, fill out a form, and I will contact you. I'm just giving a minute just in case. But I will be doing a webinar next Friday from 11 to 12, and I'm really having a whole hour to expand on maternal care, behavioral health, substance use disorders, in that realm of maternal mental health. I'll be doing that next Friday, and I'll have the QR code to give you more information about that as well. If you want to learn more, and it will be recorded, so even if you can't attend live, you'll get the recording if you register. If you're like, not really, it's not for me right now, it's not the time. If you still want to connect with us and stay up to date on what we're doing, or just like how we're involved in maternal mental health here in Alabama, you can scan this QR code, and it's just a different form about general information about the care certification, training, education opportunities, expert implementation, just ongoing information, and then educational resources. And then this is the QR code for the webinar next Friday if you would like to join that.
I also put the webinar link in the chat for them so that they can go to y'all's website.
Perfect. Thank you. And then this one last resource I really always love to share, because it's a great resource. It's called Connect Alabama. It's an app for behavioral health services and treatment finder in Alabama. And also what I love about it too is if you download it on Wi-Fi, after that you can then use it without having to be connected to the internet, which is great, I think. So it's a great app that, even that's another layer. If you're like not ready to if you just need like minimal support, this is a great way to either at least share with colleagues or people who may need it as well. So check that out. And that's just me again. And I think we'll stop there. And I went through that really quickly. So I don't know if I missed any questions, or probably about to jump into that.
Yeah, feel free, everyone, to both for Dr. Williams and for LB to go ahead and put your questions in the chat. And we can get started on questions. Anybody who wants to come off mute to ask a question? All right, I understand that. I will start the kind of, I have stuff I would like us just to kind of touch on while folks put your questions in the chat, or at any point, feel free to raise your hand so that we can call on you. Dr. Williams, I wanted to kind of ask you about Danny and her in her testimony and her kind of take on all of this as a certified recovery support specialist, talked about peers at the hospital. She also talked about women who get screened after birth, and so she also included in there about getting maybe having drug tests before and after if you're screening everyone all the time. I just wanted to get your kind of thoughts about both of those ideas as the evidence goes with peer support specialists at the hospital, but also maybe even drug screening before and after birth.
Yeah, so universal screening is always expert, as Ms. Brown just discussed. So, the urine drug screens really do not need to be that common. So when we're in labor and delivery, the common indications from ACOG for using a urine drug screen is someone's coming in and they're obtunded, so they can't speak to you, they can't respond well, you don't know what's going on. You definitely want to get a urine drug screen in that situation. Anything else, you're going to ask for someone's permission to get it. And usually, I know in Missouri, when we first started doing that, there were a lot of people that were very concerned. Well, people just aren't going to tell me. And you'd be surprised. When you ask people questions, they really will answer. So, we started doing the urine drug screens and saying, here, in order to do a urine drug screen on you, the doctor would like to see, if this could be a cause of your bleeding. And do you mind giving us permission to do that? The patients would very commonly, if they had been using a substance, say, I have been using fentanyl or I have been using methamphetamine, and this may show up on your drug screen. And that gives you another opportunity to really discuss it. And when you're having people give that permission, there's something about giving your permission that gives people some empowerment and control over their process. The idea of needing that many drug screens is in this day and age to me quite foreign. I wouldn't do that. I wouldn't need another drug screen after doing a delivery if I've done one before. The only instance I can think of where I might want to do another drug screen after would be to show that if there was a problem with the one that we'd gotten before, there wasn't enough. We needed to show that that was definitely not there. I don't know. It'd be pretty rare. Um, and certainly I would be having a conversation with social work about, if you did do a drug screen after, before the social worker comes in, I'd be having a discussion with your team. Hey, just so you know, this was after we did the C-section, after we did the crash section where the patient was bleeding and all of this, so that fentanyl may be positive in it. Um, so making sure you're having that good communication. In medicine, it becomes sometimes in the midst of, let's say, a disaster case where someone's coming in bleeding and things like that. Um, the communication can fall apart. So it behooves us to be very mindful of what we've communicated with whom and have we shared the entire story. So that's really important. And in terms of peers in the hospital, the Barnes Jewish System, which is Washington University, began using peers back right around 2020, 2021 in the hospital. They started off with just the ER, and they had one peer that would work in the ER and that would run around and see patients when they were there. And they found that it made such an impact for those warm handoffs and getting patient buy-in and communication that they began to hire more of them. By the time I left fellowship in St. Louis and moved here to Alabama, worked another year, moved here to Alabama, they had, I believe, 20 within the ER and 20 more within the system. So they found that it made such an impact, both monetarily, from decrease in repeat admissions, but also to improve the communication within the team, that it really changed how they did things. So having peers within the hospital is always a plus and should be recommended. I would love to see every hospital in Alabama have at least one peer on their ER staff, if not one in every unit.
Awesome. Thank you. Did you see there is a question in the chat?
Yeah, could we see an example of an algorithm or protocol to proceed with urine drug screening? Again, that is outlined in the ACOG bulletins. If you look, I'll try to find it for you, Stephanie. If you don't mind, I put my email and phone number up there. If you don't mind sending me a message just to kind of tickle and remind me, I will find that ACOG bulletin and send you that referral or that number so that you can refer to it yourself. But the reasons for urine drug screening in an OB patient are outlined in that ACOG bulletin. And I don't know about your docs, but for us, we were always, I mean, in training, that was your Bible, right? For obstetrics and gynecology. I had attendings that would tell you page 300 and paragraph 3, is where you find the information about this subject. And granted, we don't get it in writing anymore, so people can't do that quite as well. But most of us do refer to that as our practice manual. So let me find that actual actual ACOG bulletin for you and send that to you so that you have those guidelines. We're doing the 5 Ps or the audit C on every patient, but not sure where to take it from there. That's a really good response. And I think in the very beginning, as you're starting to implement ESPER, that is the biggest challenge that many places have. What do I do with this information? So I've had these positives, and what do I do with this information? And I think that that's what LB was talking about in her presentation, is basically giving you some tools from where do I go from here? And she'll be able to provide you a lot of that. But I'll tell you, if you have access to an addiction service, if someone's had a positive screening, that would be the first place that I would start within your facility. If you don't have an addiction service and you've had this positive sort of screen, then you want to continue that conversation. So finding someone that you can collaborate care with would be where I'd want to go next. I don't know, Stephanie, what your role is in the hospital or that sort of thing, but I will tell you, certainly, as I said before, at UAB, they call me or send me an email, set up a time, and we Zoom with the patient in the bedside and make a decision about, do they want treatment? Where do they want to go? That sort of thing. And I'm happy to help with that. But you may have some providers locally wherever you are, if you're in another facility, that may be very willing to take up that role for you. Oh, okay. Right, right. Yeah, I think that that's very true. I think that, well, UAB does have the addiction medicine fellowship, so they also have that level of screening. So honestly, with UAB, before they really get to me, they've already been screened positive by the addiction service. I'm trying to work with some folks with Huntsville Hospital to try and work out some things there, but we're having some difficulty with communication. So hopefully we can work on that as time goes by. But yeah, there are only 2 locations in the state that have a addiction medicine fellowship, USA with Dr. Eisenheimer, and then Dr. Leash at UAB. So those will have addiction services present. Yeah.
Yeah, thank you, Dr. Williams. Yeah, and I'll say for those hospitals that may not know really what to do next, again, LB and the Vital program is a great connect in that care certification conversation and really just expert for both substance use disorder, but any kind of mental health with moms that she can help you through. LB, I'm like talking for you, but Vital has a really great relationship with the Department of Mental Health, and mental health really does have connections all throughout the state that can help create some of those relationships, and LB can help walk your hospital through that. But we have reached time. If you have other questions, LB, I put her email in the chat, and Dr. Williams put her email. If y'all want to re-put that in the chat, feel free. But please feel free to reach out to them with additional questions. And I just wanted to thank you all for joining us today and for joining this webinar. If you are interested in seeing, rewatching this or sending it to someone, this will be on the ALPQC's website. It will also, our previous webinar around pain management and the ERAS protocols will also be up on ALPQ's website. So we encourage you to visit there, as well as Vital Alabama's website that's in the chat, for additional tools and resources, and as well as clinical guidance. And there is a companion blog on the ALPQC website on breastfeeding and pain medication use. So we are so grateful for y'all's time, because we know that providing effective pain management for patients with substance use disorder means that we recognize every patient deserves compassionate, individualized care, as Danny's story told us at the very beginning. So by combining this trauma-informed communication and evidence-based pain management, as well as multidisciplinary collaboration, as Dr. Williams was talking about, we can improve the birthing experience for our moms, both those in recovery and as well as those who come into the LNDs who might have their first introduction to opioids there. So we just appreciate your participation and as well as your dedication for improving care for our moms and babies in the state. We hope you have a wonderful day. Oh, also, there is a link in the chat for taking the survey. Please fill out the survey so that you can give some feedback on and get your CEUs. Thank you, guys.
Bye.